I would just like to welcome you to this session. My name's Tabitha Jones. I'm from Australia. I am a pharmacist, so when we talk about levelling up primary care services, something that's quite dear to me. I'm really quite interested about how primary care supports integrated care and integrates better. And we have some different disciplines here presenting today, so we can hear a bit of diversity in primary care. We're going to get started. We are waiting on a couple of speakers, but we will get started in the interest of time. And our first presentation today is from Ana Diaz from the University of Aveiro, and she'll be talking to us about value in primary care. Where are we? And I will just ask, we will get our presentations from our presenters and we will keep them up here for a panel, and we will ask for questions at the end of all the presentations and have a panel discussion.
So I'll use this. Okay, thank you. Good morning. First of all, I'd like to just give you some context on this work. We did it as during a proposal that we prepared, a project that we are preparing to submit to a call on science for policy. It was a project that would be financed by the Portuguese Foundation for Science and Technology, and the idea was to give some recommendations on first of all, to understand how we were assessing value concerning the assessment of primary care in Portugal. And the idea was to prepare this proposal of how to improve the model of assessment in primary care in Portugal. And that's because, as we know, the way we assess organizations and the way we assess the care that we provide affects organizational behaviors, affects the practices, affects the way we design care, and affects the performance of the individuals. So the idea was to briefly give you some context. Well, the first approach was to understand, here is some background, these new approaches of these assessment models based on this idea of value-based healthcare. This is something that is being used and applied in assessment models, emphasizing results with patient outcomes, efficiency, and this concept of patient in the center. And this exploratory work, this work that I'm presenting now, is just a result of a narrative review. It was the first step, and the idea was to understand if Portugal was ready to embrace this transformation, to consider this approach of value-based care. In a particular context that we are living now in Portugal, a context of change, we have this model, this formal model, integrating primary care with hospital care. The first experience in Portugal was in 1999 in a hospital that is in the region of Oporto. But since then, we've been having some other experiences, and now the idea is to generalize this model of formal integration of primary care with hospital care. I don't want to give you a pessimistic view of the health system in Portugal, because we have been performing pretty well in the last decades. In the last almost 50 years, we have been gaining we have been performing well concerning health results, and concerning the resources and the investment that we have been making in the means in the health, in the information systems. We have highly qualified professionals, so we have been doing pretty well. And primary health care, in particular, has been recognized for its achievements, its robustness in European comparisons. However, they still face some challenges concerning integrated care and how they are assessed. The idea with this work was to explore if in the current models that we have been using to assess primary care, was to explore if we have been integrating and considering patients and communities and professionals. Okay. So, as we know, internationally, we have been having some advances in primary healthcare performance assessment. However, still internationally, there is still a focus on costs and volume. In Portugal, so the idea with this narrative review was to assess the current state of primary healthcare performance evaluation in Portugal, and if there is really a need to improve the existing models. We have reviewed some relevant literature around these issues and also some existing public documentation on contractualization in primary care in Portugal. So we have some developments in primary healthcare evaluation. We have already introduced some mechanisms of payment by performance, mixing and combining capitation with a pay-for-performance component. The idea was to reward accessibility and quality of care. And we have already incorporated indicators trying to improve access to primary health care, disease prevention, health promotion, and even some patient and professional safety and patient satisfaction. Even so, there is still a focus on costs and volume of provision, looking at the indicators that we are using. In terms of assessing patient satisfaction, we could see that there is no uniform assessment tool adopted by the different health centers and the different family units, because we have this reform happening also. We have family units that have some degree of autonomy, and we have the health centers that are still functioning in a most traditional way. Nor there is a definition of the methodologies for collecting and analyzing data. And we have already acknowledged that the dimensions and results that are of interest to patients still are not being considered, those that value-based. In terms of professional satisfaction, it is also unclear how the evaluation is carried out, and the professionals are not involved in this process, and still this assessment doesn't have a significant impact on their performance. Concerning the programs in the community, nothing has been found concerning the assessment of these networks and experiences and programs in the community. We have identified some national primary healthcare experiences. Even yesterday, we had this presentation of a Portuguese colleague that did one particular experience of educating informal carers in her hospital, and they are not public, the results of these experiences. Well, they have results, but they are not public. So, in Portugal, there is still an excessive focus on volume and provision, and of course, it would be important to systematize, standardize instruments and evaluation methodologies adopted in primary health care, and integrate value-based dimensions, those that are really relevant for patients, professionals, and communities. The future, we are in the idea with this kind of work, and now what we will do after this is to follow these ideas and questions and and try to go more deep on these issues is because we have, the idea was to create this sense of urgency, because we believe that what we need to do is something that doesn't really imply many hard investments. So we are we are changing. We have many changings happening now in Portugal. We have already a change of government, recent elections. Now we have a centre-right party. We have some recent reforms, and the results of these reforms are not yet public. It's being built. I think we have another presentation this morning of someone from this group that is preparing this, is working on this new model of evaluation of the local health units. And they are, of course, still under study. So we are at this point. This future model will also include indicators of user experience, organizational behavior, and coordination of care. But now we still don't know these specific indicators. They are being developed. Even this extension and this generalization of this local health unit, model is a process that is not being finalized. So we will be looking at this at the future measures, and we will, as researchers, try to assess the relevance given in this new model of assessment to primary health care in this process, and what changes this model will consider concerning primary health care. Which measures of value are being created, and if we can identify some value for patients, professionals, and communities. We will try to explore if these organizational models, and specifically these local health units, that is a formal organizational model that tries to integrate hospital care and primary care, chosen from the top, as well as the payment model that will be selected, and the evaluation model, if they really is going to favor, as proposed, this integrative approach to the provision of care. So now we have many questions, okay? So some references that we used. And, well, this is a bridge, a pedestrian bridge that we have in Aveiro. And I think that's what's missing. We miss bridges between organizations and between people. Okay, thank you.
Thank you, Anna. And it's an important conversation that we've been having at the conference around how we do move towards more value-based care. And I think it's also interesting to hear from Portugal, so thank you. I would now like to invite Michael Donaldson to present the next presentation. He'll be talking about improving access and reducing costs with a primary care-based specialist oral surgery service.
Hello folks, hi, welcome to Belfast. As you can tell, I am from Belfast originally, so if you're from overseas, you're very welcome, and it's fantastic to see you. And I'm amazed how many people have come from other countries to this conference. It's just been terrific. And if you're from Belfast, good to see you. I probably already know you. So I'm going to be talking today about access to primary care-based oral surgery services. But really, when I listened to Professor Bengoa on Monday, he put a line in his talk about increasing privatisation, and the penny really dropped with me that what I am talking about here is trying to resist increasing privatisation within dentistry. So I'll try to draw that out as we go along. How dentistry operates in Northern Ireland in primary care is really, it's quite complicated. I'll do my best to sort of sum it up in a minute or two. But basically we have 360 or so practices on the high street. Those practices are owned by the dentists who work in them. The dentists are not employed by the health service. They are what we call independent contractors. So they decide what health service work they want to do, if any. They can flex between health service and private, just depending on what they feel is best for their business. And in some ways, they're a little bit like a taxi driver. If the fare is right, they'll take the job. If the fare isn't right, they won't take the job. So it's very dynamic, and it's very, very hard to plan for that. And up until this initiative that I'm going to talk to you about today, oral surgeons who worked in the high street were paid in exactly that way. They were paid a fee for the treatment that they provided. So if they extracted a particular type of tooth, there was a fee. If they removed a particular type of cyst, there was a fee for that. And it was all built up in these little fees which give them their earnings. In Northern Ireland, there are 3 secondary care sites that provide oral surgery services. 2 are in and around Belfast, and 1 is up in the northwest, close to the border, in Derry. And oral surgery really is, it's a specialism within dentistry, so you would have your regularly qualified dentist who would have spent 5 years at university doing the degree, and then after that you can do specialist qualifications, and an oral surgeon would spend a further 3 years learning really about jaw surgery. So it's not so much about the teeth, but it's about the structures in which the teeth sit. So you're talking about extracting teeth which are buried deep in the jaw, often wisdom teeth. It could be something like a cyst where you'd have to remove the cyst, or increasingly it's implants, which just seem to have taken off massively across the world. And the placement of implants, particularly in the upper jaw, is very tricky to do, and you really need to have an oral surgeon to do that. But implants are very often private, so right away you can see the tension for an oral surgeon working in primary care to maybe drift into the private and more lucrative end of the business. So what we were dealing with really here in Northern Ireland in 2015, 2016 was that the primary care-based oral surgery practices were increasing their private work. That meant they were doing less health service work. That meant the waiting times for health service work were going up and up. At the same time, those 3 secondary care sites that I showed you on the previous slide, they had very long waiting times, 2 years plus, 12,000 patients waiting. And for the sort of patients that need oral surgery, very often they are children. Children who need maybe orthodontic treatment. They can't get the orthodontic treatment until they get the oral surgery. Now, I'm not talking about oral or orthodontic treatment that is just to make your teeth look straighter and look more attractive. This is orthodontic treatment really for function. So if they don't get the oral surgery, they would lose teeth, they would have missing teeth, teeth would be damaged. So it's really quite important. The children growing up then maybe, there's a psychological impact for that. And even for the adults who need the oral surgery treatment, if they don't get it in a timely manner, they're going to experience a lot of pain and discomfort. So waiting for years is not really acceptable. So we were really motivated here to try and get access in a timely manner, and also in a way that was geographically appropriate, so people didn't have to travel too far to those 3 sites, which, as you could see, are very spread out in Northern Ireland. So this is the sort of activity that we were beginning to see towards 2015, 2016, just before we introduced the pilot. The private end of things was really taking off. So this is the health service activity, and you can see that the drop that occurred between 2014, 2015 and the following year was really enormous. And we were very worried that this was a trend that would not turn around by itself. So we were looking at essentially the collapse of primary care-based oral surgery under the remuneration arrangements, under the remuneration model that existed at that time, which, as I say, was a fee for each individual small treatment that was provided. And if the fee wasn't attractive, the dentist didn't provide the treatment. So what we did was introduced or designed a system ourselves. We did a draft version of it within the organisation that I work in, the Commissioning Health Service Organisation. And we were utilising a legal framework which is available in Northern Ireland and in fact across the UK called personal dental services. So the standard model of dentistry and primary care in Northern Ireland is very restrictive. You can really only do certain treatments and you can only get paid a certain amount for those treatments, and the monitoring and regulations are very, very tight. Personal dental services allow much more flexibility, and they also have built into them a requirement, a very strict requirement, to consult with relevant stakeholders, which is entirely appropriate. So once we had drafted up a model, we then went out to consultation with the providers and their representatives, the British Dental Association, with patient representative groups, with really anyone who would be interested in this or impacted by this. And so after consulting with these groups, we refined our model, and it was essentially co-designed the model. We drew very heavily upon a document which had been produced in England a couple of years earlier, which was all about grading the complexity of oral surgery. And that was really useful because it was an expert document and it removed a lot of the debate over whether this was a simple treatment, an intermediate treatment, complicated treatment, or a very complicated treatment. And we were able to use that to determine fees and to set case mix. So that was a really important thing for us. And just to summarise the document, it specified 3 clear levels for oral surgery. Level 1, what your average dentist should be able to do. A dentist who's spent 5 years in dental school and gone out and worked in practice. Level 2, more complicated than that. You would need enhanced skills for that, specialist skills. Level 3, definitely a specialist level. 3A, definitely a specialist level of care. Could be a specialist or possibly into the world of a consultant who would be a hospital-based specialist. And level 3B, definitely a hospital-based specialist. And really we were focusing on the level 2 treatments here because not only were they the largest in number that were being provided across the system in Northern Ireland, but they were also very appropriate to a high street specialist, a primary care-based specialist oral surgeon. In terms of the actual remuneration model that we used, one of the innovations that we introduced was essentially we would set a volume of activity with the agreement of the practitioner and the practice that we expected them to produce, and also give them an idea or agree the complexity of cases that we would expect them to see. So this was a very big shift from the previous arrangements that existed where the practitioners just saw whoever they wanted to see. It was very much a demand-led model, which created lots of difficulties for budgeting. This time round, it was prospective. We would say to them, for example, we expect you to see 1,000 level 2 patients in the next year and hold them to that. Now, we paid them the additional fees on a per patient basis, and we paid them not specifically on how many patients they saw as they went along. We paid them on a 12th, each month they got a 12th of what they had agreed would be their annual contract. And that gave them some cash flow, helped with the running of the business, which is a key element for these practices because they are just fundamentally businesses which operate in the world of healthcare, but nevertheless they are subject to all the pressures that a business would be subject to. So all the bills that they have to pay, all of the other arrangements they have to make, having a regular supply, a predictable supply of funding is very useful to them. So even though we weren't necessarily paying them exactly for the amount of treatment they did each month, it worked out at the end of the year. If they didn't deliver what they had agreed in advance, then part of the arrangement was that we would recover the funding. So if coming towards the end of the year, it seemed that they weren't going to be in target to meet the 1,000 patients that they had told us they were going to do, then we would begin to tail off the funding and recover funding to make sure that the amount that they received annually was appropriate. And sometimes that did happen, but it happened because the practices had started to get tempted back into the private end of things because that was better for their business. But nevertheless, in the vast majority of cases, we knew up front what we were going to get, and that gave us a security in terms of predicting spend and also predicting activity. We also agreed the case mix that they must see with a focus on level 2. So again, that helped us have an idea of what we would expect in terms of case complexity, but it also allowed us to go to the secondary care providers and tell them that they really should be focusing on only the cases that they can see, that the simpler cases would be taken care of in primary care. So that if a referral turned up in secondary care that wasn't appropriate for secondary care, it was too simple, they could put it into the primary care referral mechanism. We also set the term of the arrangements. Originally it was for a year, but we learned after a while that was too short, and we have now extended it up to 3 years, just to give all of those who are involved in this some security going forward so that they can make their business plans. So this just gives you a little idea of how the system works. If a practitioner sees a patient who requires oral surgery and it's a level 1 oral surgery case, then they really ideally should be seeing that patient themselves. Or if they can't see it, they should get another dentist within their practice to see that patient. If the patient is more complicated than that, then their first port of call is to send the patient to a specialist oral surgeon working in primary care. If it's more complicated again than that, and the practitioners were all trained and explained on what criteria were required for level 1, level 2 and level 3. If it's a level 3, they are to send those patients off to secondary care. Now, the referring practitioners were not always accurate in determining what was a level 2 and what was a level 3. So it's possible for the specialists in primary care to upgrade a referral and send it on to secondary care, and also vice versa for the consultants in secondary care to downgrade a referral and send it back to the specialists in primary care. So the appropriate referral was seen by the appropriate practitioner, making sure that those who had the highest levels of skill and were the most expensive to pay only saw the patients that they needed to see. So after running this arrangement for about 6.5 years, we now have 6 and a little bit more, 6.5 I'm going to say again, dedicated oral surgery specialist practices in Northern Ireland. So they focus on doing oral surgery, and that is it. Within those practices, they have 10 oral surgery specialists. So they are accredited, UK accredited, specialist level oral surgeons. They also have within those practices 24. They are subspecialists, but they are nevertheless more experienced and qualified than a general dentist. So there are 24 of that grade of dentist. And that allows the individual practices to determine, even within the practice, who is the most appropriate person to see a particular case. So it's a further level of triage and matching of patient complexity to provider skill and experience. And using this model, we hope our target is to see 11,000 patients per year. At the moment, we're at about 8,500 or 8,300, so we're not quite back to where we were. In terms of geographical access, so the red X's show where these dedicated oral surgery practices are, and you can see whilst the coverage of Northern Ireland is not necessarily equal, it's certainly more comprehensive than it was in the past. Now, when we introduced the model in 2016-17, you can see that there was an immediate restoration to levels of activity that we saw beforehand. So the fight that we were having with privatisation, it seemed at that point that we were winning that battle. But of course, shortly after this, COVID kicked in March 2020, and immediately our activity levels in primary care just dropped dramatically. And that was because of the restrictions that were placed on primary care dentistry, because dentistry was a very high-risk activity for the spread of COVID, aerosol-generating procedures, very close proximity between the practitioner and the patient, and lots of other reasons. So very, very tight cross-infection control procedures reduced activity massively. And really, since 22, we have been trying to recover activity. We're back, as I say, to a little bit over 8,000, but we're still not back to where we were before the pandemic. And this is something we've seen really across primary care dentistry in Northern Ireland and in secondary care dentistry as well. So it is a struggle to restore activity, and at the same time, we are not just trying to get back from the effects of the pandemic, we are still fighting the privatisation end of things. In terms of the case mix, it was very much focused on level 2, which is exactly what we hoped. We had those pre-ortho patients at the 12 o'clock position, which were very important to us because they were the children who weren't going to be able to get their important orthodontic treatment until the oral surgery was done. We had more level 1 patients than we would have hoped. This was really like a post-COVID phenomenon where some of the practitioners had become, the generalists had become de-skilled, and they were referring patients on that in the past they would have seen. So we're beginning to pick up effects of COVID in this model as well. In terms of the issues we face at the moment, it's the ongoing tension with privatisation, and despite the fact that in the UK and in Northern Ireland, the economic situation is not particularly bright, there does seem to be quite a lot of patients who are willing to pay privately for their dental treatment, privately for their oral surgery. So we're constantly having to get the oral surgeons back into health service oral surgery. This is difficult because there's a workforce shortage, really a workforce shortage of oral surgeons across Europe, and in Northern Ireland we are fighting to try and keep the oral surgeons in the health service. If there were more oral surgeons, it wouldn't be such a tough battle, but it is a tough battle. And when we set the fees to try and keep the oral surgeons working within the health service, there's a tension there. We're trying to set fees that are sufficiently attractive to keep them working for the health service, but if they're too attractive, then it begins to eat into the private market, and patients that would have been seen privately end up being seen in the health service. So we're trying to walk a fine line between having some sort of private market that takes some of the demand down, but we don't want to kill the private market completely, because then all of the need will fall on the health service. So for us, there's a happy medium, and if we overpay the practitioners, we kill the private market and the demand for our care goes through the roof. If we underpay, then the practitioners leave the health service and all the treatment is provided privately. So there's an access problem for particularly those who are coming from more deprived areas. So the benefits of such a system are improved access to high quality oral surgery, particularly for patients from deprived communities where they wouldn't be able to afford the private care. There's a prioritisation of patients based on clinical needs, so you're seen more quickly if your need is more pressing. The pre-orthodontic treatment for children, I mentioned a couple of times. We have much shorter waiting lists for these patients in primary care than are currently in secondary care. And we have better geographical access. The practices are located more conveniently, and the patients are happy going to those practices because they feel more comfortable, more relaxed. The anxiety that often goes with a formal visit to a hospital, particularly for dental treatment, is not so severe in a primary care setting. From the provider perspective, because we are now on the 3-year arrangement, there's greater business viability. They know where they stand financially. They're able to make plans going forward. They're also able to vary how many patients they agree to see with us. So if their capacity is reduced, for example, if a member of staff on maternity leave, they can dial down the arrangements. So that flexibility, they like that keeps them happy. And as I said, within their practices, they are able to match the complexity of the case to the skill of the operator. Lastly, for the Commissioner for the Health Service itself, we have been able to so far sustain and secure the service. We have an effective and well understood referral pathway that's well embedded in the consciousness of practitioners across Northern Ireland. They've learnt the system, they know how it works. We've been able to get a full range of level 2 treatments provided by practitioners, oral surgery practitioners on the high street. We've massively reduced inappropriate referrals to secondary care, so secondary care is essentially only seeing the cases that it should be seeing. All of this has led to a much more efficient system. So the cost of a patient seen in primary care is about £200 per case. If that patient were treated in secondary care, the exact same patient, it would be about £1,000 per case. So it's 1/5 of the cost if we can keep these patients out of secondary care. And from my perspective as a Commissioner of Health Services, because we have the upfront prospective arrangement of how many patients are going to be seen, I know how much that's going to cost, and I'm therefore able to budget more effectively for that spend. Thank you very much, and I'll take any questions later.
Thank you so much, Michael, and I'm sure that you'll agree that was really interesting. I think our dental friends are not always at the table when we talk about integrated care, but there's been some other presentations in dentistry at this conference, so I think it's great to be looking more laterally at what health means for people. And I think that really is a good example of a project looking at that right care for patients in the right place at the right time, and that equity agenda, people getting care who need it most. So thank you. We will save our questions for the end. And for our next speakers, I'm going to invite them up if they'd like to just join our panel when they've finished speaking, and we will have a conversation at the end. So save your questions up. I'd now like to invite Denise Hall to come forward if she's here. Hello, Denise. Denise will be presenting on Be Connected for Health and Wellbeing, Primary Care Multi-Disciplinary Team, First Contact Physiotherapy Service, Enabling Self-Care and Community Connections. Thanks, Denise.
Thank you for the opportunity this morning. I'd also like to introduce Claire Convery, who's the head of our community partnership in the Clanrye group and integration, and she's going to be speaking with me as well. So I suppose we'd just like to set the scene of where this is coming from. This is our experience in Northern Ireland, where we've been partnering with community and voluntary sector to improve the opportunities for self-care and promoting physical activity. So in the opening address in the plenary session on Monday, you heard about our local Bangor report that has led to the delivery plan, which is Health and Wellbeing 2026. So two of the aims of that delivery plan were about building capacity in communities in the prevention to reduce inequalities and to ensure the next generation is healthy and well. Another aim that is aligned to this project is provide more support in primary care to enable more preventative and proactive care and earlier detection and treatment of physical, mental and health problems. So primary care multidisciplinary teams have been set up in Northern Ireland in a few of the federations. The federation that we're going to talk about is Newry District GP Federation. It's one of 17 across Northern Ireland. So we're situated in the southeastern part of Northern Ireland, and within the model of delivery, they've introduced new roles into primary care, which are first contact physiotherapy practitioners, social work practitioners, social work assistants, and mental health practitioners. Currently, we're delivering in 14 of the 29 practices within our federation. So for any of you who don't know what a first contact physiotherapy practitioner is, they're an advanced practitioner. They have a range of advanced skills. They're able to provide a musculoskeletal assessment. They're identifying red flags. They're non-medical prescribers. They can provide injection therapies. But they also have a key role in self-care and the management of MSK conditions. So as we know, about 30% of GP caseload can be musculoskeletal conditions. So that expertise in primary care is what we're delivering. So what we decided was a key strategy was about early intervention and optimising self-care in musculoskeletal conditions. And whenever we started, we were just a month in before COVID hit. So we were only a very small team. At the start, there was only 3 first contact physiotherapists. And one of the things we were struck straight away was the levels of physical activity within the patients who were present within general practice. So with the challenges of COVID, we thought this is a good opportunity maybe to gather a bit more intelligence around this. So we undertook a survey to understand patients' awareness of the Chief Medical Officer's guidelines on physical activity. So that's guidelines throughout the UK. And they have been tailored towards different age groups, people with different types of conditions, and really in a drive to try and inform the public around what keeps us healthy, what levels of physical activity that we need to undertake. So there is a baseline ongoing health survey in Northern Ireland, and this was the data that we did have access to, was back in 2016, 2017 around physical activity. And we looked at kind of the status of where patients were in terms of being able to comply with meeting those guidelines. So there was an overall rate of 57% reported in that particular health survey, but you can see there's a significant difference between the most deprived and least deprived areas of Northern Ireland. So in our own survey, we managed to get 72 patient responses, which we thought was really good, in 6 GP practices, and we asked them a range of questions. So we asked them around what their levels of physical activity were, and about 65% of the patients were doing either 2 sessions or less in a week, which was really concerning. But another area that we want to look at was confidence and actually just trying to get started. Where do you get started? And really there was very poor confidence levels, about almost a third rated between 0 to 3 out of 10 of confidence and how they would go about it. And we asked them what would be helpful, what could help you become more physically active. So there was a large proportion of them were telling us, about 66%, they needed a bit of guidance on this, particularly from a healthcare profession or from supervised sessions to help them make that start. And then we also looked at the reasons why they felt it was preventing them from being more physically active. So COVID definitely was a barrier at that time. We were under strict lockdown, so that was significant. But also what was significant was the number of people with physical or mental health conditions and also their own motivation. So what did we do about it? Well, we felt it was important that we had kind of a multi-faceted approach to this, because certainly there are many factors involved in people becoming more physically active. So we decided to plan for a range of service improvements that we hoped would improve this. So we developed electronic resources, so at that time everything was online. So we developed a web page with our GP Federation, and we connected patients to things they could do online as well. We also connected them to the community and voluntary sector's information and advice, and also advice on musculoskeletal conditions that they could access. So that could be accessed by all GP practices across the Federation, by patients. It wasn't just the ones that we were in. The other piece of work that we did was improving health literacy training for all the MDT staff who were in practice. We undertook that. And also we looked at how could we connect people to the information. So we used within the GP record, there's an opportunity in certain operational ability within practices to send information directly to the patient's phone. So we tried to do that. And also we looked at how could we involve patients in producing something that would help them connect to other things in their local community to become more active. So when the restrictions raised a little bit, that's our webpage, we planned a community connection event. So we decided to do this in Annalong, which is a small rural village, very far away from a lot of health services, definitely from hospitals, and had quite a high demand from a musculoskeletal point of view of conditions and patients who were struggling. So we worked with our own MDT colleagues, because this needed to be all-encompassing. It couldn't just be about physical activity. And our project manager and our leads for mental health and social worker, we liaised with the trust and the community and voluntary sector, and we tried to get as many organisations together to an event, and 37 of them turned up, so that was pretty good. And we were able to get patients to come into a local community hall and find out a bit more about what was available in their local community. So that was pretty successful. The patients had helped us plan for this event, so we co-designed it together because they knew what would work, the timing of it. They knew who to invite, how to get the word out. Simple things like how to actually find out, particularly in COVID, because it was quite hard to get information around to those people most likely to benefit. So it provided a good template for us going forward to use that kind of model again. And we also wanted to explore, was there any opportunities with our community partners now that COVID restrictions had been reduced to actually deliver on this. So within the primary care multidisciplinary team model, there's what they call a seed fund. And this allows us a bit of flexibility in trying out different projects within different populations to see what works. So small amounts of money. So we identified 2 areas within the Federation. One was in Annalong that I talked about earlier, and the other was in Banbridge, which is kind of an urban town, quite a high population. And what we asked the patients was, what would help you get more active, what would encourage you, so that they definitely felt that they needed some kind of qualified staff. So the Clanrye group, and Claire's going to tell you now what they did, they were able to provide 12 weeks of physical activity opportunities in those 2 areas, and all of the coaches were GP referral qualified.
Thanks, Denise. So we've conducted our research. We know who we're trying to target. We've been told the barriers that we have to overcome. Where do we start? So timing was important. We launched this project in mid-January, so the start of the new year, and that was purposeful. New year, new resolutions, encouraging people to come along. The barriers that had been identified are, firstly, people don't know where to go. They want it somewhere local. We're breaking down costs, etc., etc. So you can see from the posters, we're giving as much information on that first contact as possible, and these leaflets are being handed to a person from their physio, from their GP surgeries, their primary care, their pharmacists, and then just in the local community also. You can see by the wording we've used things like easy circuits. We've chosen a morning routine, strength and balance, things that people mightn't understand have that little descriptor. And then if you haven't learned this in your 3 days already, people from Northern Ireland love their tea, and especially when it's free tea. So free tea and coffee, free classes. This is how we're capturing the audience and bringing them in. So we've pulled some of the key stats from our report, and over the 2 projects and the 12 weeks, we had 84 participants. So we weren't expecting that amount of people, and that was a huge success. And if you can see there, 68 people retained the programme for the 12 weeks. So for us, that's massive, an 82% retention rate. We from our research, we did know the kind of community that we were targeting, the group, but mostly it was people who are currently physical inactive, have a health condition, and don't know how to access physical health. So the GP referral in the community setting, as Denise has already said, was key for us, and that gave us some of our most important stats. 40%, remembering this is a 12-week project, so a small project and lots of learning, but knowing that this is something that we need to sustain and make longer. But having 40% reported improved fitness over that 12-week was a key step for us, increasing flexibility and improving balance, so just so important. Why you believe us when we can show you a patient experience. So these are some of the ladies that took part in the project. You might have to believe us.
We did check this morning, first thing.
enjoyed it. I felt it was good for my mental health as well, and it certainly made me more flexible, and I enjoyed the bit of crack with the girls. Just the fact of me time and getting into the zone and doing the breathing and doing the gentle exercise, and it wasn't too much, so it was within my capabilities, so I enjoyed that. It gives you something to do in the week, it gives you a focus. You have to go to class and you get up and you do it, and it was all about keeping moving when you get older.
I have arthritis, a frozen shoulder, and I have 90% loss in my knees in the cartilages, so I'm building up muscles on my bottom leg and top leg. Well, I thought Emma Gosh was absolutely brilliant. She didn't put any sort of strain on anybody, told them to do it at their own leisure, and she went along with everybody's pace, and that made quite a difference. It was so enjoyable. Afterwards you could go to sleep, you're lovely and relaxed. It catered for my needs 100%. I felt a lot better in myself. I mean, confidence, self-esteem, you name it, it improved everything about 100%.
Very relaxing. I find it de-stresses you really, and just really a good feeling, a feel-good factor whenever you finish the class. Meeting after the class and having a cup of tea or coffee, discussing the class and that. Yeah, looking forward to it every week. I live on my own, so I like to socialise and keep active and combined all those things.
But sort of be kind of anxious sometimes. I found that the classes were very good for relieving sort of any tenseness or anxiety that maybe I'd had that morning, or even coming to it. I always felt more relaxed when it finished.
So for us, that's given insight to the impact of the project, both physically and mentally for the participants. I come from a community development background, and we believe strongly that that community development approach is vital. So simple things like that initial phone call to explain the context and the format of the class, to reassure people, to tell them what to wear simply, to tell them where to come, to know that there'll be someone there to greet them. If you've spoken to the person that's actually taken the class before you get there, that's relieving any anxiety or a lot of anxiety that you may have about attending. So those wee key things that we learn in community development, to me, are vital for this project. The time and the reassurance that the instructor has, because they're supported by other staff on the day, to give people that reassurance. So, you know, to listen to their background, to reassure them that they have that training in GP referral exercise, and to know that we had this culture that historically that if you're injured, rest, don't move, but now we know the learning is the more we move, the more helpful that's going to be. It's all about movement. So reassuring people and giving them that confidence that they're not going to further injure themselves, or that this is actually going to help, but also that they can do it at their own pace and they're not going to be forced to do anything that they don't want to do. So for us, that was massive. And as I've said, the tea and coffee, the social time, and I knew that would get a wee mention in the video as well. Signposting. So 12-week project, we're always coming back to that. You know, that's what we're funded for. It's not enough. We need longer term funding. We need these projects to be sustained. But in community development, the best thing we can do is signpost. So 12 weeks is mostly enough to give people that confidence that they could then move into the community or the services that are already there. One key element of a barrier, it was proposed as finance. So community development then are going to have the community sector, and when we're funded and partner with other organisations, we're going to be able to break down those barriers to provide either low cost or no cost programmes for service users. And then also, even like during this, the cost of living increase, etc., people don't want a monthly subscriptions. They still need to be able to pay as you go. So that's important for people as well. And again, keeping it local is key. Going down to your local community hall, going to your local leisure centre. So again, that's all about the financial elements, but just giving people that encouragement to be able to attend. What did we learn from the project? That yes, there is a huge gap in services for accessible physical activity. So that's the key. There's lots of physical activity classes out there, and they're popping up more and more, but it's not accessible for people who primarily have a long-term health condition, and that's what we need to focus on and need to change back to the funding, reoccurring funding. That's key for us to allow these things to keep happening, and to partner with our statutory organisations is really helping. Classes again, local, keeping it local and accessible, and being able to measure it. So, you know, we have to prove evidence in some way, and we did use measurement tools, but nothing that we really found could be covered in such a short space of 12 weeks. Mostly the health and wellbeing improvement measurement tools need a longer experience. So back again to that financing and reoccurrent funding, of course. So the retention of staff. So when we have these excellent staff, as again was mentioned in the video, and you know they're exactly the staff that need to be doing this work, but mostly then they're hired in for a short period of time, or if they work within the community sector, they're moving on because we can't ensure any sustainability in our own projects. Meeting the person where they're at, that's massive. So you can come together with a group, a like-minded group of people. They're all coming from similar backgrounds, from similar location, but they're not in the same place. And that's a community development approach again. It's meeting someone where they're at, giving them the time, the encouragement to find what they need to continue on, and to equip them with the tools to really take ownership of their own health. Okay, so next steps. What did we do next? Knowing that this project was a success, and even though it was only delivered over 12 weeks, the impact that had was massive for us, and why we wanted to team up again and do something else. So we're thinking about what other groups of people need this help, need to look after their physical activity and improve their health. One of the projects that we ran currently it was social supermarkets. So you're meeting people who are currently suffering from food poverty. So that's the last thing in their mind. You know, if they can't afford to buy a weekly shop, the last thing in their mind is their own health or their physical activity. So how do we target this group, improve their physical activity by meeting them where they're at? So it's back to, again, those key community development approaches. We're bringing people together from similar backgrounds. So again, we're breaking down those barriers. We're not making them feel self-conscious. It's all about being that first face, you know, and welcoming somebody in, holding their hand and bringing them in. And then we're almost disguising the physical activity around this. So we're picking something that's like really easy to do. You're almost tricking them into doing physical activity without realising it. So the likes of your more holistic approaches, your Tai Chi, your Pilates, your yoga, etc. And the Time For Me project, again, was a great success because we were able to bring these people together. It was all about time for me. So let's forget about what's going on at home. Let's forget about the struggles that you're currently facing, and take this hour that you're switching off. This is for your mental health, your physical health, and you're doing some gentle activity. And week by week, then they're realising this is actually improving my health, and this is making my mental health stronger, and that's going to help me make better decisions. So they are all interconnected. And one quote we had from one lady was, "This is the only time in the week for me to look after myself. I have children with special needs, and the rest of the week is full on." So just getting that hour away was massive and had such a great impact for her. So thank you.
Thank you, Denise and Claire, and I'm sure you agree that that was a really great presentation. I think this conference has asked us to hold some space for our consumers and our communities and listen to what's important to them, and I think this is a really good example of listening and responding to those needs. And it's interesting, a cuppa in Australia, a cup of tea, is a very good draw card as well, so I feel like it might be a universal language. I'd now like to invite Yeuk to the stage for a presentation. He is from Khoo Teck Hospital, and he will be talking to us about systemic lifelong care services, integration using Yishun Health's unified care model and health system transformation playbook.
Hi. So we've heard from Belfast. So now I invite you to go to Singapore, where we are doing very similar things. But my role in Puat Hospital, I am a service planner, a system designer. So although we are trying to integrate lifelong care services, primary care services for the population, my role will take you kind of like to the planning space where we look at segmentation models and connect a little bit with the speaker from Portugal about evaluation. So this is where I come from. Singapore is divided into 3 zones. You see the central part, we have the National Healthcare Group. My hospital is actually in the Yishun zone, right at the top, the northern part of the central zone. So my hospital system cares for 300,000 people, and we work with different partners that come together to provide healthcare services. What do we provide? So inherent within my system, we have Puat Hospital, Yishun Community Hospital, and Admiralty Medical and Surgical Center. So we were very much an acute center, and this phase of our development, we are trying very hard to integrate with the community services, the primary care services, and the GPs out in that northern space I showed you. So a lot of the work we are trying to do now is on the context of the government and the ministry moving towards a fully funded capitation model where we have to ditch what we used to be fee-for-service types models, and then we have to move into that holistic funding model. So a lot of that provides the context of why we need to integrate care with our partners better in order to be able to sustain what we want to do within the capitated funded models. So this picture shows you some of the current initiatives that are already happening in lifelong care. So I will start with the left side first, where we actually, because Puat Hospital does not provide primary care by ourselves, so we already were working through partnership offices with the GPs and primary care services to provide pre-emergency care, community screening services. We run shared care programs between the GPs and our specialist outpatient clinics. And also, there are some collaboratives going on to generate diabetes remission programs with the GPs in order to reduce the burden of chronic disease. Then on the far right side, you see some of the community frailty prevention programs, very similar to what I think the previous speaker was doing with the community. We provide, here the share a pot that we're talking about is we provide soup. So it's, there's coffee and tea as well, but we bring people to a community center where the community enjoys a pot of soup together, and then they reduce loneliness. They have to walk to the center, and then while doing that, they do a little bit of exercise as well. The Dance Up and Step Up programs are very similar to the rehab programs the previous speaker spoke about, but it is in the types of activities that the community partners and the patients are familiar with. The Dance Up is instead of doing physical rehab, they try to do some line dancing, you know. And instead of pulmonary rehab, they try to do karaoke. There's another program that is not mentioned there. That's a karaoke program. But these things alone are insufficient, and there is still a group of people who come to the acute hospital, to our ambulatory care clinics with significant chronic disease burden, They are always with our specialist outpatient clinics because their care cannot be optimized well. So we started this integrated medical clinic 1.0, which brings our specialists working closely with the family as well as a range of behaviorists as well as rehab therapists together to put together an integrated care service to improve the outcomes of the specialist outpatient clinic. So in the 1.0 version of this, we appointed a primary coordinating doctor who will helm this integrated medical clinic and pull all these services together. And the next phase of what we wanted to do was to integrate this integrated medical clinic with the community frailty prevention programs on the right side, as well as with the GPs out there so that the shared care partnerships could be continuous and seamless between the ambulatory settings in the hospital and the primary care settings in the community. So this was what we were thinking about doing to increase the seamlessness and the whole process of lifelong care. So in order to do that, we conceived of what we call a unified care model, which we term as a demand-sided model. Because my hospital, my ambulatory specialist outpatient clinic is what we call a supply-sided services model. So there are numerous supply-sided services model, right? So it could be a profession-based model, it could be a site-based, hospital-based model, it could be a disease, musculoskeletal condition-based model. So we conceived of a need to describe a demand-sided unified care model that represents the needs, the totality of needs of the patient from the need side, from the demand side, and then use that to align and integrate all the services models on the supply side that we are providing together. So in this model, you see at the top part, the green part, if we look after patients in the lifelong sector, if we manage their conditions well using ongoing maintenance, then we prevent worsening that is significant and permanent. If we do it well, we might potentially even create improvement that is significant and permanent and move them to the left side, right? The shift left programs have been mentioned quite a couple of times. So at the same time, we also do this in a systemic way. So anyone in the lifelong care segment, if they suffer from a crisis, they will be escalated into an episodic segment in my hospital, and then upon treatment, resolved back into the lifelong segment. So this is the model that we use to then think about how to integrate various supply-sided services model to create a unified lifelong primary care integration. So based on this, we were able to look at the population segmentation models built for the green part, right? So we segmented the whole 300,000 population in the north of Singapore into 7 lifelong care segments. I won't go into the details there because the segmentation model has been described in a parallel session in this conference. At the same time, if they arrive in my emergency department with an acute condition, then they would be attributed into 6 acute segments in the hospital. So today I'm focusing more on the top part, the green part, the 7 segments and how their care will be integrated. So this is a services strategies model that says that anyone and everyone in one of those lifelong segments will require one care plan strategies, and they need enrollment into a primary coordinating doctor or primary clinician who will formulate a one care plan with comprehensive person-centered needs assessments and goal setting, and then we would execute that one care plan across the multiple services, whether in the community, in the GPs, or in the ambulatory outpatient clinic in the hospital, right? And then, of course, there is community development work that also needs to be ongoing in the community to provide that envelope or that container for all these to be integrated into the family and in the community space. So using these 2 models, the lifelong care segmentation model as well as the services strategies model, we conducted multiple stakeholder engagement conversations. And these conversations were designed to bring the different perspectives, whether they are from the community, whether they are from the ambulatory clinics or from the primary care clinics, and to together frame the context of change, as well as to encourage redesign of processes to bring the services together. And you can see a list of things that emerge from some of these multiple stakeholder conversations. They are by no means exhaustive. So one of the key things we were struggling with was the scaling up of the primary coordinating physician or doctor program to be able to enroll sufficient numbers of patients from the segmentation models. So that became one of the top of the list transformation activities we need to pursue, and we are actively working on that one. You might be wondering why cardiology, renal, diabetes clinics, etc. are involved. So I spoke a little bit about, we tried the IMC 1.0, right, the Integrated Medical Clinic, which was our pilot to start integrating care for the complex patients that keep coming back to the specialist outpatient clinics. And we started that pilot, but we did not have enough services providers to be able to meet the needs of all those in the higher complex segments, the segment L5, L6, and L7, right? So because of that, that became one of the most important tasks that we need to do to increase enrollment. And of course, workflow redesign to the various departments that need to work together at that scale for that number of patients, and also workflow redesign with GPs and polyclinics. And we are also, in another parallel session, we described the development of a unified needs assessment model to improve needs targeting in the One Care plan. And lastly, patient registry and dashboards to be able to track outcomes and evaluate the total cost, utilization, experience, and chronic disease management outcomes for each of the population segments. So this is an example of the engagements that were done for different subspecialties, encouraging the specialist doctors to come on board to become primary coordinating doctors for those complex chronic disease patients. So the numbers of PCDs that were subsequently enrolled are indicated there. We are still in the progress of scaling it up. And these are the numbers of patients that have been attributed to different IMC 2.0 clinics after we have enrolled the PCDs, and the numbers are trying to reach the numbers that are predicted by our population segmentation models. These are an example of the hospital system dashboards looking at the lifelong care segment. Segment by segment, we were able to describe the total number of patients enrolled per individual clinician, and then look at the outcomes of the population segment, the L5, L6, L7 population segments, as well as the utilization by population segment and the outcomes and cost by population segments. So this is kind of like evaluative. It's more for operational management, but we think this can be taken further for evaluation as well. Last but not least, I mentioned at the beginning that this is part of a services transformation, services integration effort. So we learn from the process of working with the different stakeholder groups, and we kind of articulated a methodology for process and services redesign called the Health System Transformation Playbook. It has got 3 steps, starting with storytelling by different partners and providers, different stakeholders, coming together to build the futuristic services model that they think will integrate care together. And then after that, finding paths that each of us, each stakeholder can take to bring their activities and processes forward towards that model that they articulate together. So the model that has been built includes the unified care model, the strategies model, as well as some of the dashboard models that we have articulated. It's published in a paper, so if you scan the QR code, you can get to the full paper itself. There's no time to go through the whole thing, but I want to talk about some of the major takeaways to end. Change and transformation is a very complex process. A lot of things need to be transformed at the same time by different teams, in different subsystems, and through time, coherence need to be achieved and maintained. So context is very important, but we need to bring that context into a cascade of interdependent models. You see how the models link to each other. Segmentation model links to strategies model, links to process models. And so that when you have this cascade of interdependent models, you can ensure coherence of change and transformation through time. And then those models then prescribe paths for individuals to change. This whole process needs to be iterative, as if a sequential process, but not always, to achieve that systemic whole system change and transformation. And lastly, we need to make sure that we address immediate challenges that are important to every single team and stakeholder. And then that means that we need to be polarity ready. We need to be able to address what they need and point to the future at the same time. So this requires us to use implementation science that is systemic, and that's an example there, Health System Transformation Playbook. So with that, I thank you. These are some of the great people that I've been working with that has given me this opportunity to share with you what we have done together in Singapore. And those who would like to speak more about this with me, that's my QR code there to my LinkedIn profile. Yeah, thank you very much. I'll take questions later.
Thank you, and that was again another insightful presentation. And it's interesting to see Singapore, because you're in our region with Australia, and we're very interested in what's happening in our wider region as well. I think that concept of lifelong care is one of the privileges of being primary care clinicians, that we do get to do that journey with our clients right through their life. I would like to now open up the floor to questions. If anybody's saved up some questions, we have a microphone. And just pop up your hand and feel free to address any of our panellists, or they can answer your question between themselves. Don't be shy.
Thank you. Michael, this question's for you. I noticed there's a big gap whenever you look at the map of Ireland, or Northern Ireland, no Tyrone, no Fermanagh. Couple of things for me, maybe to understand the reason for that, and then what happens to the patients in those areas. And by developing a new service, if you like, to meet risk, have you created health inequalities? Sorry, lots of parts to it, Michael.
Yeah. I don't have my microphone.
Is it working? You can come up here if you want.
Yeah, okay. Yeah, so one of the other things I should have mentioned, actually, I mean, there's just so much in the way primary care dentistry in Northern Ireland operates, is that the practitioners are free to set up wherever they want. So it's very much a business-driven model. Even if they're working within the health service, they make a determination where's best for them. And basically, in the west of Northern Ireland, it's not as attractive to dentists in general and oral surgeons in particular. And we find there's a sort of phenomenon, and I think it happens across the UK, is that dentists tend to work closest to where they've trained. So because the dental school is in Belfast, as you get further from Belfast, the attractiveness, particularly for younger dentists to work there, is reduced because the referral opportunities are less into secondary care. So we do definitely have this spot in the southwest of Northern Ireland where not only is access to dentistry in general not good, but access to oral surgery isn't so good either. And in terms of the patient's options, they just have to travel, unfortunately, and that there's no way around it. We could create something outside of primary care or a bespoke service where we did fix the geographical location, but that would be something different from what we're currently doing, where we essentially put it out to the market. And the model that we run is incredibly efficient. That's why we can get oral surgery operations for £200 versus £1,000. It would cost us more to specifically set up a centre and salary a practitioner, an oral surgeon, to go and work in the southwest, but we might have to do something like that to overcome those inequalities. Was there a third part that I... yeah. Yeah.
I was wondering, do they go into trust services?
They probably no more so than any other part of Northern Ireland. I think, you know, there are established geographical inequalities there, probably that go beyond dentistry as well, and unfortunately they have maybe come to accept that travelling, because it is quite rural and the population is quite you know, is quite sparse, it's not very dense. With that comes maybe an expectation that they might have to travel. So yeah, we probably do need to do more to try and make sure that there is a bit more equity there.
No, thanks very much,
Okay,
Michael.
Grant.
Hi, thank you for the presentations. I think they're some of the best that I've heard at the conference over the last couple of days. I had a question that was to do with non-reoccurring funding. It was the MSK presentation, and I think that's something that we struggle with as well in England. So when you're running something for 12 weeks and you've got engagement from that community and they really want it to carry on, but you've got non-reoccurring funding, how do we break that cycle of almost disappointment in the community where you're moving on, the funding forces you to move on?
I'm not sure, is this working? It is, yeah. Yes. It's a huge challenge, and I suppose you'll have heard in other presentations around the need for a recurring budget. And I don't want to do the politics bit again, but that's what we need. So if there was a programme for government that had real engagement with community and voluntary sector, which had earmarked over a 3-year plan, that would help the continuity, if you like. The money that we've been privileged to have access to is short-term, small pockets of money, but it is to model different ideas to maybe help inform a larger regional picture on what that should look like. But yes, when you've got people engaged, you want to keep them engaged, and I suppose that's the benefit that Claire's team were able to do, was to what there was available, they were trying to encourage people to access after the 12 weeks. And I mean, we did have some good examples of people who were never going to the gym. These are not gym people we're talking about, you know, they just never have that confidence. But actually some of them did start going to classes that were available, that were low cost. So that was a good outcome. But it's not perfect that we don't have something recurrently. And I suppose if we had a regional framework around where, if you like, health sits, and as we've said in other speakers, you know, the workforce is also within our community and voluntary sector as well as within professional staff. So we do need a strategic approach to that.
Yes, good question. I would have asked the exact same one. It's a struggle for us, but from a community development perspective, we never disappoint people or leave them. We can only do what we can do, and as Denise said, we'll maybe move them into other programmes, so it mightn't be exactly what we were providing, that we were funded for, but we'll always signpost people into something, and even if it's just that connection, a social connection, we'll have ongoing social cafes that will never end. That's something that, you know, we're doing in-house, and we're constantly sourcing funding and, you know, moving people around, but it's a massive struggle, and there's no solution at present.
Yeah, thank you.
If I may add to that perspective, so I was kind of describing a strategic approach and premise of segmentation that allows us to evaluate the total cost of improving lifelong care outcomes for a community. So we face the same problems where we need to sustain the things that we are doing. because of a capitated situation, right? So when we put all the different services on the same level and look at them, we then are now able to see which of these services can help the primary care population reach the outcomes intended at possibly a lower cost. And that's where the community development pieces come in. Again and again, some of the things that my specialist outpatient clinic is providing could be helping to achieve outcomes but are extremely expensive to achieve that outcome. And if I could move some of that money to the community development arm in the space with my partners, then we could do more dance-up programs or step-up programs that achieves that rehabilitative outcomes without my rehabilitation providers in the hospital providing that. So it's kind of like a model where we now can do services planning, paying attention to the outcome as well as the cost of individual services, but anchoring it down to a population segment. And then that gives us ability to work with our partners and shift resource and shift costs to where it can be done better, more person-centered, better experiences for the community and for the residents.
Thank you. I think that just shows how that integrated care model gives that better visibility for commissioners to make those decisions, because it feels like there's so much value in prevention and community initiatives, and is so cost effective as well, but there's no real focus at the moment from commissioning on sustaining that. So I think it's a really interesting challenge. I especially like the dentistry 3-year contract, because just having that stability and that knowledge, how much further you can progress with that. If we could have the same in community initiatives, I think it would fly. But thank you.
Hello, the presentations were amazing. Thank you so much. For Singapore, I'm sorry I forgot your name. This is the second presentation I've seen by your group, and I'm really impressed by the segmented model of care. And I kind of have like a takeaway that when you're looking at system integration, you need those interdependent dashboards or metrics or models in place, a framework. For initial steps, so if you were a new system, looking at incorporating a segmented population care model, what recommendations or lessons learned could you share?
Sorry, can you repeat the question again at the end?
Sorry. If you were talking to a new system that was looking at developing a similar system, what lessons learned or for startup with starting the frameworks and so forth, those interdependent frameworks, do you have any words of advice or lessons learned that could help a group kickstart that?
I think our first speaker in the plenary, Raphael, spoke about systems, not structures. I think it's absolutely spot on, and the recognition is that everybody plays a role. However, what everybody does need to come together into effective systems. But there are so many systems that make up the larger systems, right? So I need my financing systems, I need my informatic systems to work well with the services delivery systems. So I think the first recognition is that we are here to build a whole that is larger than what each of us are doing, and that requires a systems approach. And then the second recognition or advice I would say is that we really need to be model driven, and each of us need to check that our models are working well with each other's models so that we can amplify the total outcome by all the people working together to integrate care, whether at the front line or at the back room. So I think that's I could go on and on about this, but these are the two that I think are the most important takeaways that I have personally come to recognize as important. The leadership, clarity, and focus on what that mission is about, and using systems to enable it will help a lot. Yeah.
Thank you. Any more questions? I think we've done well with time. I think that concludes this session. I would like to thank you for coming along, and I would especially like to thank our speakers. I think this was a really good array of presentations, and we've covered a lot. The insights were wonderful. I would like to thank you for the work that you're doing in primary care, because primary care does carry a lot of work in our healthcare system. I think we've heard a little bit about the impacts of COVID, and I think that primary care has felt that. But I think that it's hopeful. I think that there's really good work going on, and the things that we've heard about today across a diverse range of professions and systems and countries. So I'd like you to join me in thanking our speakers for their time and the work that they're doing.